Um, Hello everyone, welcome to this finals crash course series on gastroenterology. We've got Dr. Sakshi this evening who will be teaching us today. In the top corner of the slides is our Instagram link. So if you give that a follow, you can see all our upcoming sessions and get in touch with us there as well. And at the bottom, we've got our email address if you want to ask us any questions at all or get involved with our teaching, please do send us a message. Next slide, please. So here's the link to the polls, so you can answer along as we go. Great. Next slide. All right, so Sakshi, I will hand it over to you.
Sure. So hi guys, my name's Sakshi. I'm an FY1 that's just working at Ealing Hospital, and I've just come off gastroenterology. So today I'm going to be talking or teaching part 2 of gastro. And just a quick note that any underlying topics on the slides have already been covered kindly by Ellie in part 1. So if you missed that, then do check back on the recordings to see those topics. Great, so I thought I would start with sort of a combination of single best answers, and then we can discuss the answer and then talk about those topics. I think people have said that that was the most helpful way to learn. So the first question is about Mr. Jones. So he's a 45-year-old gentleman who presented to A&E with 2 episodes of coffee ground vomiting. His past medical history included lower back pain, and he takes regular ibuprofen for this. And he also admits to drinking a glass of wine 3 times a week. So when you're taking your history, you also find out that Mr. Jones has been reporting a 2-month history of this severe epigastric pain that comes on whilst he's eating. And as a result, he's lost his appetite and just doesn't feel himself. So if you guys want to just click what you think the most likely underlying cause for his presentation is, and then we can talk and discuss the answer in the next slide.
Okay, so we've got some answers coming in for B and some for C.
Great. Yeah. So yeah, so it's definitely an ulcer, I think, that we can agree on. And I think the key risk factors for that are obviously his regular ibuprofen use and the sort of episodic severe epigastric pain. I think the main differentiating fact between gastric ulcers and duodenal ulcers that you can find in the history are sort of the onset of the pain. So gastric ulcers the pain seems to come on while they eat the meal, and then duodenal ulcers tend to come on after the meal. And I like to think of where they're positioned with regards to obviously the GI tract. So while they're actually eating food, then the food would irritate the ulcer in the stomach, which is why the pain comes on more quickly. But I'll go into a little bit more of that detail when we talk about peptic ulcer disease later on. Great. So I thought I'd start with gastrointestinal bleeds, which are one of the most common gastro emergencies, and it's really good to sort of know a little bit about it. I think it's quite a common topic in finals. So normally they're split sort of into upper GI and lower GI bleeds, and this is to do with where the location of the bleed is. And it's actually separated by the ligament of Treitz, which you can see this diagram here in the middle, which is in the second part of the duodenum. So it's an arbitrary sort of landmark that separates upper GI from lower GI bleeds. And you can see the main symptoms of an upper GI bleed would then vary with regards to fresh red blood or via vomiting, which is hematemesis, or melena, which is dark stools, whereas lower GI bleeds tend to present more with sort of fresh PR bleeding, although it's not an exact science. And I've also listed some of the most common causes for each of these, and I've gone in order of most common to least common. So obviously peptic ulcer disease is one of the most common causes of an upper GI bleed, which is why I thought we'd focus a little bit more on that. So yeah, so they go from most common to least common, and like I mentioned, the underlined topics have already been covered in the previous section. So if you're interested, then do check back on the recordings with those. So with regards to investigations and diagnosis for a GI bleed, so like with everything, you want sort of a full set of observations. You want to assess whether this patient is hemodynamically stable or unstable. And obviously you would use an A to E approach to assess any patient that presented with sort of any symptom. But with regards to specifically about GI bleeds, you want to make sure that you've got electrolytes on place, which you can get quickly through a VBG. You want to make sure you've got a urea as well, and you want to have a chest X-ray just to rule out perforation through a pneumoperitoneum that you can see on a chest X-ray. And all of these specific blood tests I've highlighted allow you to calculate what's called the Blatchford score, which is a tool that's used to assess the severity of the bleed and also give you some indication as to what management would be required. So, for example, if you look down on the management box, you can see that a score of 0, you would consider an early discharge with outpatient follow-up, where sort of anything above a 0 essentially would require an inpatient admission, and then anything above a 6 would need an urgent review and consideration of urgent endoscopy. So with regards to history taking as well, obviously if the patient is unstable, you wouldn't waste too much time on this, but if they were able to give you much of a history, then you'd want to quantify the bleed, ask them about any hepatic or cardiac failure, again, because that makes up the Blatchford score, and then check their alcohol history and when they've last eaten, and that helps you plan endoscopy for them. Cool. So the next question that we'll move on to is part of, again, GI bleeds, but it's talking about Mr. Smith, who is a 60-year-old gentleman who's presented to A&E with frank hematemesis. So like we mentioned, that would maybe highlight more towards an upper GI bleed. On admission, he has a heart rate of 120 and a blood pressure of 88/60. So he's hemodynamically unstable. And on examination, he looks pale, and you can see a distended abdomen with visible spider nevi. So next to him, he has a vomit bowl with about 500 mils of fresh blood, and the nurses are telling you that this is his 3rd episode of hematemesis in the department. So talking about what we've seen so far with GI bleeds, what do you think your initial management plan would be for Mr. Smith?
So there's something about A
and
about C.
Yeah. Cool. Great. So I think the trick in this question is the initial management plan. So like we were talking about, obviously definitive management, you would want to get them an endoscopy, but in order to safely do the endoscopy, you need to make sure that patients are appropriately fluid resuscitated. So an A2E assessment for everyone, appropriate fluid resuscitation, and you always consider giving them IV PPI in patients with a GI bleed. I think the terlipressin is the interesting add-on for this particular patient, and it's because we were thinking the most common cause of such a presentation would be esophageal varices, which would indicate underlying liver impairment. So patients who present with upper GI bleeds that you strongly suspect are due to varices are often given sort of prophylactic terlipressin that will then continue if this is confirmed on endoscopy. So that's the one key difference on this case versus any sort of other patient that would present with hematemesis or an upper GI bleed. So just to quickly recap what we've talked about for management so far. So an A2E approach, 2 wide bore cannula for aggressive resuscitation, and you want to replace like for like. So if you can see obviously a vomit bowl full of blood, you want to make sure this patient is getting blood. And do remember blood product ratios when transfusing a lot of blood. So you want to make sure they have the appropriate then platelets and FFP then as well prescribed, especially if they're getting multiple units of blood. And what you also want to consider is if this patient is on any anticoagulation, then you want to correct their clotting. And then obviously you can consider tranexamic acid and other specialized drugs with obviously consultation with gastroenterology. But the key difference that I was sort of hinting to was terlipressin and prophylactic antibiotics. So prophylactic antibiotics are used if there are known cirrhotic, but if anyone who presents with a strong suspicion of esophageal varices is often just given terlipressin in order to help their portal systemic circulation, essentially, and try and control the bleeding. And then endoscopy is obviously the definitive management. So for varices, they can be banded, and other non-varicose bleeds, then if it's an ulcer, for example, they can be injected with adrenaline to stop the bleeding. And I've just put this in as a worst case scenario, but because I think people see it in textbooks quite a lot. So the Seng-Stack and Blakemore tube can be inserted in very, very specialized circumstances, but it's often the last resort, and patients need to be intubated for that to happen. So it's often very rare and not at all what you would do sort of first line for patients. And then I think many of you would have also heard about the Rockall score, which can actually only be calculated post-endoscopy, because you can see that there is a section for the diagnosis, which gives people certain points. And then essentially, if their post-endoscopy Rockall score is high, then you would have to plan for a rebleed and then consider ongoing management. But if it's very low, for example, then they can be considered for discharge as well. So for a variceal bleed, if it's a confirmed one, you would continue terlipressin and continue antibiotics, because it's likely probably caused by liver cirrhosis. And then for non-variceal bleeds, you want to make sure you check the CLO status or the CLO test that they would have done on endoscopy to identify H. pylori, and then start them on the appropriate treatment for that. And just a quick sort of summary of lower GI bleeds, because I've mainly focused on upper GI bleeds. Lower GI bleeds kind of, I guess, are managed more by the surgical team, so I wasn't sure whether to include it in this presentation, but essentially, if a patient is hemodynamically unstable, so if their heart rate is high and they're hypotensive, then essentially most of them will have a CT angiography to identify the source of bleeding. And then depending on where that is, that can be treated accordingly, either via surgery or via like endoscopy, so colonoscopy or flexi-sigmoidoscopy. So varices, I thought I would just highlight clearly. So varices are caused by hypertension in the portal circulation. So what that does is it causes portosystemic shunts of blood, because blood isn't able to pass through a cirrhotic liver into the IBC. So as a result, it has to divert and go into other parts of the systemic circulation to try and return back to the heart. So I've listed the three main areas of portosystemic shunting, most commonly in the esophagus, but it can also happen in the rectum or even in the umbilicus. And so these are often key sites of bleeding for patients with liver cirrhosis. And then just some causes of portal hypertension. So hepatic causes are cirrhosis, and in the same way like pancreatitis, but you also have to remember you can have prehepatic and post-hepatic causes of portal hypertension. So not everyone with varices has to be cirrhotic, although this is the most common cause. For example, prehepatic causes are things like thrombosis, and post-hepatic would be an IBC thrombosis, for example. So depending where the thrombus is would make it pre or post-hepatic. So the third question is about Mr. Jones's wife. So Mrs. Jones has also been suffering with persistent reflux and epigastric pain after eating. So she goes to her GP, who refers her for an outpatient endoscopy. And unfortunately, the full report hasn't come back, but they do notice that she's had a positive CLO test on the system. So with regards to what we've talked about with regards to CLO tests and H. pylori, what do you think the appropriate management plan would be for Mrs. Smith?
We've got most answers going for B.
Okay, cool. A bit of a trick one. So you're absolutely right with regards to that they would need 2 antibiotics and a PPI as part of the H. pylori eradication. But if this is her first time that she's had H. pylori, often the duration is for 7 days. So you would start off with a course for 7 days and then obviously reevaluate and see if her symptoms have resolved. Great. So just to come back quickly to peptic ulcer disease. So peptic ulcer disease is sort of the end point of peptic inflammation, and peptic inflammation is sort of split into esophagitis and gastritis and duodenitis. And the risk factors for both are quite similar. So for esophagitis is GORD, essentially reflux, but also certain drugs can cause it, so NSAIDs and bisphosphonates. And similarly, these can also cause gastritis and duodenitis. H. pylori tends to mainly cause gastritis and duodenitis, obviously because it's present in the stomach and duodenum. But then lifestyle causes are also important to consider. So obesity and smoking and alcohol. So alcohol histories are really important in these patients. That then progresses to develop either a gastric or duodenal ulcer. And like I alluded to in the first question, The symptoms can be slightly different depending on where the ulcer is present. So for gastric ulcers, it's worse while eating and then improves after a meal, whereas duodenal ulcers will improve while eating initially, but then the pain will occur several hours later. With regards to just key points about each, so gastric ulcers are more likely to undergo malignant transformation, so they often need a repeat endoscopy to check for resolution, especially after H. pylori eradication is delivered. Whereas duodenal ulcers are less likely to be malignant, but unfortunately more likely to perforate via, especially posteriorly, via the gastroduodenal artery. So often patients that present with sort of upper GI bleeds are tend to more often than not tend to have duodenal ulcers rather than gastric ulcers. So the next SBA is about Mr. Jacobs, who is a young gentleman, 23-year-old, who presents to his GP with some PR bleeding and mild diarrhea. So on examination, you notice these dark brown spots around his mouth and on his hands and feet. His past medical history is unremarkable, apart from a hospital admission for intussusception when he was 5 years old. But interestingly, when you ask about his family history, he informs you that his father died from colorectal cancer at a very young age of 38. So I guess this is sort of like a two-part question. Initially, what do you think the diagnosis is? And then as a result, what would be the expected findings on colonoscopy?
So some people are going for C and some for E.
Okay.
Yeah, so that's most of them.
Cool. So yeah, C is definitely the right answer. And I'll just go on to the next slide and we can talk about why that is the case. So polyps are interesting. There are many, many different types of polyps, but I've tried to group them into 3 main types of polyps. So inflammatory polyps, neoplastic polyps, and I can never say this, but I think it's hematomatous polyps. Essentially, this patient is most likely to have an underlying diagnosis of this Peutz-Jeghers syndrome. Again, I don't know how to say it properly, but essentially it's a familial polyposis syndrome that affects young people. And they have these quite typical symptoms of dark brown spots around their mouth and on their hands and feet. And essentially they are found to have many of these specific type of polyps. So although these polyps, hematomatous polyps, are not neoplastic in and of themselves, having that many of them does lead them or predisposes them to develop colorectal cancer, which is why his father would have passed away at such a young age. So neoplastic polyps often occur in the elderly population, and they're often associated with smoking and a high BMI and red meat. So they're often in sort of how your elderly population develop colorectal cancer. They're not associated as such with any familial syndrome, if that makes sense. So it's quite rare for a 20-year-old to have neoplastic polyps. And then inflammatory polyps, as the name suggests, is probably associated with any causes of inflammation. So that would include inflammatory bowel disease, recent surgeries, ischemic colitis, or anything that could cause infection or inflammation. And these are sort of the most common types of polyps, inflammatory polyps, especially in patients with inflammatory bowel disease. And often 20% of these patients can have at least one polyp. So the main symptoms to think about, so if the polyps are left-sided, you can often have frank blood and then all this alternating constipation and diarrhea. But if they're right-sided, they tend to have less overt blood, just because obviously the blood has to travel longer through the colon so that when it comes out in the stools, it's often not as visible as a left-sided polyp. Okay, so we're about halfway. So the 5th question, Mr. Clive is a 78-year-old gentleman who presents with severe left-sided abdo pain. He also suffers with chronic constipation and he takes regular lactulose for this. On admission to A&E, he is pyrexial, has a temperature of about 38.5 and has quite raised inflammatory markers with a CRP of 200. When you examine him, he's very acutely tender in the left iliac fossa with some associated guarding as well. So what do you think the most likely diagnosis would be?
Most people have gone for B.
Mm-hmm. Nice, yeah. So a nice question. more straightforward question, definitely diverticulitis. He's got clear risk factors for this. He's an elderly gentleman, especially with chronic constipation. So chronic constipation leads to obviously more stress on that particular area, particularly the sigmoid colon, which can cause these outpouchings that then are at risk of perforation. I think this was covered in the previous topic as well, so I won't go into it in too much detail. But nice, yeah, this would be a clear presentation of diverticulitis. So acute abdomen is a pretty massive topic. There are many, many different causes of an acute abdomen. Essentially, an acute abdomen is sort of defined as acute abdominal pain lasting less than 1 week with no clear history of trauma. So on a history, again, you want to take a really good pain history for the abdominal pain. You want to ask about associated symptoms, including nausea, vomiting, change in bowel habit and urinary symptoms. And then obviously think about what other things can cause an acute abdomen. So don't forget a gynecological history in women. So ask about discharge and last menstrual period, as well as think about systemic symptoms to rule out your red flags for cancer. So investigations are quite broad spectrum. Basically, as you can see, the number of causes for an acute abdomen is so high that we want to sort of rule out a lot of things. But basic things like regular bloods, a VBG, and don't forget to send off your pregnancy tests, especially in young women. So I'm mainly going to try and focus on obviously the gastrointestinal causes of an acute abdomen, given obviously the topic of this presentation. But I've listed all of the others, or not all, obviously not comprehensive, but a lot of the others, just so that you guys can remember that when presented with any question about an acute abdomen, you need to think about other systems as well. Cool. Oh, so I thought this diagram was quite helpful just with regards to the causes of an acute abdomen and how to think about them. So at the top, you can see the type of pain. So obviously it's not an exact science, but this tends to be in questions the rule of thumb. So if someone presents with gradual pain that's getting worse, then it's often the itises, so inflammation, that tends to get worse. So cholecystitis, hepatitis, diverticulitis, appendicitis, any of these that cause inflammation that obviously will get worse with time. Also important to remember salpingitis, so inflammation of the ovary and, oh my God, fallopian tube, as well as ectopic pregnancies, which can present similarly. If a patient presents with sort of an abrupt excruciating pain, then perforation due to peptic ulcer or perforation due to any of those other causes are top of your list. But don't forget to rule out acute MIs or heart attacks and also ruptures of AAAs. If it's sort of an intermittent colicky pain, then depending on the location, you're thinking biliary or renal colic, but also small bowel obstruction and inflammatory bowel disease are also things to consider. So those all will sort of present with crampy episodes of pain that may get better over time and then come back with a vengeance. And often they'll describe a history of the pain-free interval getting shorter and shorter, so they might eventually end up with gradual steady pain, but often they do have these sort of crampy abdominal pain episodes that they can tell you about. Okay, so appendicitis, which is the most common surgical emergency, is essentially inflammation of the appendix, and the symptoms are sort of right iliac fossa pain is classic, but often people can tell you about a pain that started in the periumbilical region that then moved to the right iliac fossa, which is to do with parietal and visceral innervation of the appendix that I won't go into too much detail. But typically the pain is at McBurney's point, and it can also cause things like anorexia and fever, nausea, depending on how inflamed or how infected the appendix is. So the classical examination question will talk about Rovsing's sign being positive, which is essentially that when you press on the left iliac fossa, they get pain in the right iliac fossa, and that indicates peritoneal inflammation. Oh, sorry. I think something's going around, a bug. So essentially they'll have raised inflammatory markers, and imaging is not always helpful, especially ultrasound, because often the appendix is not visualized, especially retrocecal appendixes, which are actually the most common location of the appendix anyway. So many surgeons, if a patient has a clear history of appendicitis and has clear examinations that would lead you to believe that this is appendicitis, many surgeons will also offer sort of laparoscopic appendicectomies even with normal or inconclusive imaging. But essentially the management involves IV antibiotics to treat the infection, IV fluids, obviously, because these patients are at risk of becoming septic, so you want to make sure you do your sepsis 6, and a prompt surgical removal of the appendix. So do remember sort of your atypical presentations as well. So retrocecal appendixes may not always present so classically, and in children, the pain may be a lot more diffuse and not so localized. Cool. The 6th question is about Mrs. Singh, who is an 88-year-old lady who presents to A&E with crampy abdominal pain and vomiting. She has not opened her bowels for the past 5 days, and her past medical history includes type 2 diabetes, hypertension, and a previous stroke, which has left her completely bedbound. She has no surgical history, and an abdominal CT is performed, which confirms a small bowel obstruction, but no mechanical cause for the obstruction can be identified. So what does everyone think the most likely underlying cause for this obstruction would be?
Some answers for A,
Mm-hmm.
some answers for B.
Okay. So I think this is, a bit of a tricky one. So although sort of adhesions and inguinal hernia are the sort of 2 most common causes of a small bowel obstruction, I think in the question, you can rule out adhesions based on the fact that she has never had any surgeries before, which makes her developing abdominal adhesions very unlikely. And then an inguinal hernia, although it doesn't actively sort of mention that anyone's done a groin examination on her, I think she has key risk factors for pseudoobstruction, of which the most likely cause are electrolyte disturbances. So pseudoobstructions are basically bowel obstructions that have all the same symptoms of a bowel obstruction, but without any mechanical cause. And the main risk factors are elderly patients, especially bedbound patients, of which she is one. So I guess B or C you could consider, but given her risk factors, I would say pseudoobstruction is slightly more likely in this case, but I guess an argument could be made for hernias as well. So just to talk about small bowel obstruction, again, you can have sort of luminal causes of small bowel obstruction, so something physically blocking the bowel. Extraluminal, which is the most common type of small bowel obstruction, which you're right in saying adhesions and hernia are the 2 most common causes. Essentially, they block the bowel from the outside, so adhesions outside the bowel. And then actually within the wall of the small bowel, you could have things like malignancy or Crohn's disease, which is inflammation of the small bowel, obviously that extends through all 3 layers. So the symptoms are obviously colicky pain, we talked about that on our previous diagram, but also vomiting that often occurs first, and severe abdominal distension. And a complete bowel obstruction, patients will not open their bowels at all, so they'll have complete constipation. And the key finding on an abdo x-ray is the central gas shadows with this valvulae conniventis, which are sort of lines that you'll see on the x-ray in the next slide that run through the entire length of the bowel, that completely cross the lumen. And that's often how you can differentiate in your spotter exams between small bowel and large bowel obstructions. So the management, often patients will be trialed on a conservative management first for obstructions caused by adhesions or where perforation is not present. So obviously if an obstruction is caused by an adhesion, doing surgery may result in more adhesions. So you want to definitely try conservative management first. Any patients who are perforated and presenting and are unstable are obviously would be taken to surgery, but otherwise you can consider trialing conservative management, which would involve sort of keeping the patient nil by mouth, putting in a Rouse tube or an NG tube to decompress the stomach, and then giving them appropriate analgesia and antiemetics. And then obviously you can also consider giving them gastrographin, which can help also reverse some small bowel obstructions. But if all of this fails, then this patient would be taken for a laparotomy. Oh, so these were the x-rays I was talking about, but just quickly. So I was talking about pseudoobstruction, which are the clinical features of obstruction without any mechanical cause, and long periods of immobility, electrolyte imbalances, and drugs are sort of the key risk factors and causes of pseudoobstruction. So large bowel obstruction, a lot of the same features as small bowel obstruction, but the most common cause is malignancy, especially in your older population. And again, this will be colicky pain, but often based on the location, the vomiting will occur much later, and it'll be like feculent vomit rather than biliary, like bowel stain vomit. They will also have absolute constipation, and on abdo X-ray you can see a gas-filled bowel, and you can also see these haustra, which are transverse lines that do not cross the entire width of the bowel. So I've just put both of these X-rays in to just highlight the differences between the valvulae in small bowel and these haustra in the large bowel. So I used to always get this wrong, so I thought I would just include it. So number 7, Mrs. Grant is a 46-year-old lady who presents to her GP with episodic crampy abdominal pain following her meals. She notices it's particularly worse after a heavy meal and usually settles on its own after an hour or so. She's otherwise well and has no past medical history, and her GP refers her for an abdominal ultrasound, which confirms the presence of gallstones. So given a presentation, where would you expect the gallstones to be located?
A lot of people going for A.
Yeah. So yeah, to be fair, so I think we all agree that she has biliary colic. And so key thing about biliary colic is that the stones are often present either within the gallbladder or in the cystic duct, but with no associated inflammation. The only reason I picked B over A was because oftentimes gallstones located within the gallbladder tend to be more asymptomatic. So the fact that she's actually having symptoms would perhaps lean more likely to the stones being within the duct. But you're very right in saying that it should be associated with no inflammation of the gallbladder for it to be biliary colic. If she did have associated inflammation of the gallbladder, that would then progress to cholecystitis. So yeah, definitely A or B, but given that she is symptomatic and often symptomatic quite regularly, I would lean more towards the fact that the stones have moved slightly down into the cystic duct. So gallstones are essentially hardened bits of bile that form in the gallbladder. So as you can see, they can either form within the gallbladder. These are often asymptomatic unless they're extremely large stones, and can or locate more at the neck of the gallbladder in the cystic duct. So if that happens, and I've put little stars as to along this picture of where gallstones can obstruct. So the first little star at the neck of gallbladder or in the cystic duct can lead to either biliary colic, like we were just talking about, and obviously if it completely blocks the duct and causes associated inflammation, it'll then lead to cholecystitis, which is inflammation of the gallbladder. If it does, however, travel slightly further down and block the common bile duct, what you essentially have is then a total blockage of bile, which would then lead to acute or ascending cholangitis, and that obviously will cause jaundice, essentially because your common bile duct is completely obstructed. Further down, if it blocks the ampulla or the sphincter body, then it can cause, in addition to complete biliary obstruction, it can also cause pancreatic duct obstruction. And very rarely, if it does pass into the duodenum, it can be one of the causes of a small bowel obstruction if it's such a large stone that completely obstructs the duodenum. So with regards to gallstones, risk factors, I'm sure you all have heard of the sort of 5 Fs that people talk about. So females are most likely to get it, especially women in their 40s. If they're overweight or obese, that's again another risk factor. And oftentimes it affects Caucasian women. So if they're fair, essentially that is also a risk factor. Family history of gallstones is another one to think about, and particular drugs, especially the combined pill, is an important one to remember. So investigations, again, it's radio opaque in only 20% of cases. So actually the ultrasound or an ultrasound first line and second line MRCP are often preferred as sort of investigations rather than going for X-ray or CT. And then complications depending on obviously where the gallstone is and what can cause. So gallstone ileus, I talked about, if it does block the duodenum, and then it can also cause a mucocele or an empyema around the gallbladder, depending on how bad the inflammation gets. So the 8th question. So unfortunately, this patient, Mrs. Grant, was not offered any follow-up and her symptoms began to worsen. So 3 months later, she presents with severe abdominal pain and vomiting. On admission, she's pyrexial and has a raised white cell count, CRP, and alkaline phosphatase. On examination, she is extremely tender in the right upper quadrant, but she is not jaundiced on examination. So you don't notice any overt signs of jaundice. So what do you think, with regards to her current presentation, would be the most appropriate management strategy for Mrs. Grant?
So we've got most going for B and then some for D.
Okay. So definitely analgesia, IV fluids, IV antibiotics, and antiemetics are your conservative management. So definitely that for her is important. So for this patient, it's important to categorize. I think she has acute cholecystitis, and that's because she's pyrexial. She's not jaundiced, so we don't think she's got complete biliary obstruction, but she's got inflammation, raised inflammatory markers, and likely inflammation of her gallbladder, which gives her acute cholecystitis. So with acute cholecystitis, the definitive management would be offering someone an operation to take out their gallbladder. So it's often done a laparoscopic cholecystectomy. Sort of a couple of years ago, up until sort of a couple of years ago, it was thought that these operations should be delayed until the initial sort of sepsis and stuff had been treated. So they were often delayed sort of 4 to 6 weeks after patients were discharged from hospital. But I think a study was done that showed that people often represented then within that time frame, and often had repeated episodes of sepsis and acute cholecystitis. And so currently the guideline is that with patients presenting with acute cholecystitis, where possible, laparoscopic cholecystectomy should be offered within sort of 72 hours in order to help them have better long-term outcomes, essentially. So I used to always get very confused between biliary colic, acute cholecystitis, and cholangitis. So I've just added a little summary table in here, which hopefully helps you to differentiate between the two. Essentially, cholangitis, we talk about Charcot's triad, which is a combination of obviously pain, fever, which is a sign of infection or inflammation, and then jaundice, like I was mentioning, because your common bowel duct is obstructed, so bowel cannot pass through, and it starts to become stagnant and build up, so that causes jaundice. And then obviously for acute cholecystitis, we need to remember that patients are often Murphy sign positive, which means that when you press into the right iliac fossa, then patients will have a lot of pain, and then they often catch their breath, and that would be a positive sign. And it's only Murphy's positive if they then don't have a similar finding on the left side. So you need to actually do the sign on both sides for it to be a true Murphy's positive sign. So the treatment for all three of them is actually quite similar. If it's simple biliary colic, then you can consider an ERCP to just remove the gallstones, and a delayed laparoscopic cholecystectomy. I've sort of discussed why in acute cholecystitis people need surgery sort of within 72 hours. And then for acute cholangitis, it's actually quite scary when people present with acute cholangitis, because they're often very, very unwell. So your main priorities are focusing on stabilizing this patient, and they will often need to have a drainage of their biliary tree, which can be done via ERCP, just based on where the stones are located, and obviously them presenting with jaundice and biliary stagnation. Cool. Our last question is Mrs. Brown, who is a 75-year-old lady who presents to her GP with terrible diarrhea. She reports 5 extremely watery stools a day and is feeling generally very unwell. She suffers from COPD and has recently been admitted to a hospital multiple times in the last 3 months with repeated infective exacerbations. She is currently completing her 4th course of antibiotics from her last hospital admission. What do you think the most likely cause of her diarrhea is?
So lots of people have gone for C.
Yep, exactly. So key risk factors are sort of repeated courses of antibiotics, and this can lead to sort of C. difficile infections, which can be actually quite debilitating, especially in the elderly population. They can become very unwell with these, with C. diff. So quickly, just to run over diarrhea very briefly. Diarrhea is defined in an acute or chronic state based on how long it's been going for. So often acute episodes of diarrhea are caused by infection, and chronic can be a variety of causes. So it can be infective, or it can be caused by malignancy, inflammatory bowel disease, or even pancreatic insufficiency. So with pancreatic insufficiency, you would expect, obviously, a different type of diarrhea that floats at the top of pot, and that's called steatorrhea. The different mechanisms of diarrhea I've also listed. So you can have an osmotic cause, where essentially absorbable, non-absorbable substances in the lumen of the gut pull water into the lumen, because and this can be caused by things like malabsorption or lactose intolerance. Secretory cause, or where the colon itself secretes water into the lumen. That's often either an infective or inflammatory cause. And then anything that causes increased motility can also lead to diarrhea. So things like thyrotoxicosis and diabetic autonomic neuropathy, or even irritable bowel syndrome. Of note, though, irritable bowel syndrome is a diagnosis obviously made by exclusion, so you want to make sure you've done the appropriate investigations to rule out other causes of the diarrhea. So C. diff is a gram-positive spore-forming bacteria, and it's often associated with prolonged antibiotic use. And just clear red flags for diarrhea. So it's often quite a concerning sign in patients above the age of 50 who've had symptoms for longer than 6 weeks. And that's when you'd be thinking about your red flags for cancer. So you want to make sure you always ask about change in bowel habit, any bleeding, unintentional weight loss, night sweats, and any family history of bowel cancer. And any patient presenting with a microcytic anemia or anemia in general, especially in men, elderly men, you would be very concerned for cancer. So our last slide is just a quick summary of celiac disease. Again, another common cause of diarrhea, often in the pediatric population, but it's an autonomic condition essentially causing damage to the small bowel as a result of hypersensitivity to gluten. So the immune system attacks the bowel because of their hypersensitivity to gluten. So essentially the symptoms are chronic diarrhea, malabsorption, and often in the pediatric population this can cause a failure to thrive. So investigations are obviously an anti-TTG because it's an autoimmune condition, but you also want to make sure you send off an IgA titer level, because if the patient is not producing IgA for whatever reason, then this test you could have a false negative. And then the definitive diagnosis would be a biopsy. And if you see on this picture here, you can see that the top is normal and the bottom is celiac disease. So in patients with celiac disease, you can see that the little villi are very flat. And these are the 4 sort of key terms that we use to describe the biopsy for someone with celiac disease. So you can see the villi have atrophied or are not so present anymore. There's hyperplasia of the crypts. You can see quite a lot of lymphocytes, which I appreciate would be quite difficult to see on such a small picture. And essentially you have inflammation of the lamina propria. And obviously any extraintestinal manifestations of the disease, because on examination, these are what you're looking for. Obviously anemia, any joint issues, so arthralgia or arthritis, and then this quite peculiar rash called dermatitis herpetiformis, which is often associated with or occurs mainly in people with celiac disease. And then often keep a lookout for peripheral neuropathy, either secondary to malabsorption, so B12 and folate deficiencies. So untreated celiac disease may also cause patients to develop small bowel lymphomas or cancers. So it's very important that you do get on top of diagnosing these patients and treating them appropriately. And the management is unfortunately just a strict gluten-free diet. So that wraps up the presentation. I hope it was useful, and I'm happy to take any questions.
Perfect. Thank you very much. So we've got the feedback form there. If you could fill that one out, and then that's the end of the session. Thank you, Sakshi.
Thank you so much.